So we are going to start with the basic thing that is for fresh postgraduate and all new consultants. So in hand, it's one of the most essential structure with multiple joints, different types of ligaments, tendons and nerves. So hand injury accounts for almost 28% of all injuries. So hand injuries can be classified into the following categories, that is laceration, fracture and dislocation, soft tissue injuries, ligament injuries and amputations, infections, burns and high pressure injuries like grease and paint guns, which is a contaminated injury. So these are the examples of hand injuries. You can see different type of cuts like crush injury, burned hand and traumatic amputated hand. Dry gangrene of both hands, gunshot wound to the hand. Then osteomyelitis is found and then extensor tendon injuries. So we are going from bone to the soft tissues. So diagnosis of hand injury requires a proper history taking, clinical examination, then establishing a provisional diagnosis. We never jump directly on the diagnosis. The diagnosis should be supplemented with appropriate radiographs, CT scan and MRI if necessary. So how we approach to the hand injuries is a basic general examination, age, dominant hand which is right or left. Then according to occupation, because occupation we plan the further treatment and we take the further follow-up and we can change the actions. Whether he has addictions which affect the nerves and wound healing like tobacco, chewing and alcohol. When and where did the injury take place? What was the mode of injury? And then coming to the clinical examination. Always start with the inspection. You have to see the attitude of the limb, visible swelling. First always go for the local warmth, tenderness and range of motion, then shift to the spatial test. So look, move, feel and measure. That is the basic principle of examination. First we confirm the inspection, then palpation and range of motion. Then we shift to the muscle and tendon function. First aim is to save the hand, then the function of the hand, then neurological testing, then vascular assessment and then spatial test. So inspection, normal finger cascade. Always we see the finger pointing whether which is towards the thenar eminence or not. Then the deformity of the fingers, deformity of the wrist and other things. Then swelling and wounds and scars whether they are adhered or not adhered. Then tropic changes. Then thenar and hypothenar atrophy. Again we have covered this point in the palpation. So neurological, sensory, light touch and pinprick. We should have proper examination tools. We should have proper examination kit at the OPD where you have to point out at the sensory part. Then motor, we focus on median, ulnar and radial nerves. So these are some examination points. We start with the examination of ulnar nerve. This is the Igawa test for the ulnar nerve. With the palm flat on the table, the patient asked to move the middle finger sideways. Test for the dorsal interossea of middle finger. In total client, median nerve is also injured. Then foreman sign, everybody knows. Flexion of thumb, interphalangeal joint, if adductor pollicis is weak, it is the only muscle which is supplied by the ulnar nerve, adductor pollicis. Then to test ulnar nerve motor weakness, this test is positive if patient's first MCP joint is hyperextended on pinch. Then Peters test to sign, inability to actively move middle finger in radial ulnar direction or abduct to either side with the palm face flat on the table. You have to keep the hands flat on the table. Then the card test, the test to test the palmar interossea, inability to grasp the card suggestive of weakness of palmar interossea. Then Wattenberg sign, involuntary abduction of fifth, that is little finger due to unopposed action of extensor digiti minimi due to weakness of ulnar nerve. Then signs of median nerve, benediction sign, Pope Benedict sign, inability to flex index and middle finger at MCP and IP joint. Then everybody loves this sign, OK sign, inability to touch the thumb to the index finger. Then radial nerve, wrist drop, inability to extend the wrist, thumb extension test, inability to extend the thumb against resistance is suggestive of radial nerve palsy. Then special test in hand and wrist, ballotment test of wrist to assess the TFCC injury, always compare with the opposite side and assess for ballotment in all planes. Always start with the normal part and then come to the affected part to be examined. So this is a ballotment test. Then ulnar foveal sign, tenderness is the interval between ulnar styloid process and FCU, between volar surface of ulnar head and pacciform. Then pronosupination stress test, aggravation of pain on pronosupination of the wrist. Watson test to see for dynamic stability of wrist. The examiner grafts wrist with the thumb over scaphoid tubercle and wrist moved from ulnar to radial deviation and you experience presence of clunk, that the test is positive. Then radiological assessment of the hand, all clinical signs has to be supplemented with the radiological investigation to confirm and support your diagnosis. X-ray is the first choice of investigation in hand injury, and it should be done in the baseline as a baseline part. If we are suspecting dislocation, it's very important to get a true lateral so that the injury should not be missed. So case 1, 32-year male right hand dominant occupation came with alleged history of cricket ball injury to the right ring finger. On clinical examination, he had tenderness over PIP joint. So this is an X-ray which is considered to be normal. We can see PA view and oblique view. Then coming to the further view, that is dead lateral view, you can see a good fracture, which you can compare this with this. So right ring PIP fracture dislocation. To emphasize further, lateral view is not enough, dead lateral view is necessary. So this is the lateral and this is the dead lateral. You can see the difference. We may miss the injuries and later on patient comes with the deformity and inability to work. And as you see, as the IT professional, it is very important to get the dead lateral view. Then how to take a dead lateral view? This is the image which shows how we take the dead lateral view. Finger must be in dead lateral rotation away from the other fingers, and finger must be parallel to the cassette. So this is the way how we take the dead lateral view. Then if the X-ray, we are assessing the both views, we are more or less showing in the same picture. True lateral view of the thumb, projection from the above, keep rest of the hand elevated from the cassette so that the radial mid-axial line of the thumb touches it. This is how we go for the lateral view of thumb. Then other special views of the thumb, Robert view and stress views. So Robert thumb view, a true AP, wrist pronation, dorsal of thumb parallel to table, and imaging beam on trapezio metacarpal joint. This is very important where we put the imaging beam. Then X-ray of the thumb, that is Robert view, useful to diagnosis of first CMC arthritis. Then the stress view, you can see, you have to compare with the opposite hand and you confirm the diagnosis for the CMC instability. Scaphoid, everybody knows, scaphoid tenderness. Scaphoid injuries can often be missed on routine radiographs. Radiographs that should be done in scaphoid injuries are PA, lateral view, scaphoid view, PA with ulnar deviation, semi-pronated oblique view, and clenched pencil view. So these are the views, PA with ulnar deviation, lateral, and semi-pronated oblique. So you get the 3D orientation of the scaphoid and you can plan the treatment accordingly. Sometimes we feel that it's undisplaced fracture, and with these views, we can see that there can be a displaced fracture, and we will miss the proper treatment of the scaphoid. Now this is the clenched pencil view. So gripping pencil, press a card between the first dorsal interosseous muscle and keep the forearm away. To assess for dynamic scaphoid unit widening, show snag and slack wrist, which is the better in this view. So wrist injury standard radiograph should be PA, not AP. Always we order AP views. Frankly speaking, AP, it's not a AP, it should be PA view. More importantly, they should be in PA in neutral forearm rotation. So ulnar process in center. Then PA view of the wrist. First is AP, second is a PA. The other special views, Witten view to assess articular counter of metacarpal head and MCB joint for concentric reduction. So this is the way we do 65-degree flexion of MCB joint, dorsum finger lying flat on the X-ray plate. Then carpal tunnel view, everybody knows for carpal tunnel assessment. So conclusion, the complexity of hand injuries requires a thorough clinical radiological correlation so as to plan management of the injuries. Many injuries are often missed and thus require special views in the addition to clinical examination to have a better understanding of the injuries and come to the prompt diagnosis. So thank you very much for patient listening. Thank you.